Welcome friends once again to our NPTEL MOOC module on health economics. This is a 12-week module covering different nuances of health economics. This is our third sequence of this particular week. We are emphasizing on equity in health financing. In the previous lectures, we started discussing about distributive justice, then we emphasize three theories of distributive justice, especially utilitarian models, egalitarianism, and Maximin theory as proposed by John Rawls. And also we discuss about health frontier and trade-off and the social welfare function for health. In this lecture, we'll be clarifying the aspect called vertical equity and other important directions in the concept of equity called concentration curve, concentration index, then Kakwani's progressivity index, then horizontal equity. So, in the introduction we want to mention once again that health equity is very important. Unless equity has both positive as well as normative aspects. Positive means which is considered to be relevant in the present period and is evaluated by the person, whereas normative means it stands for a specified label or as is prescribed by the norm. Hence, positive analysis is commonly undertaken to describe or measure the distribution of health and of healthcare use and of the way in which payments for healthcare are shared between different people in society. Normative are indeed based on judgments about which equalities define equity and which inequalities define inequity. So, for an example, are inequalities in payments for healthcare or in healthcare use or in health across income groups and inequitable. So, equity in the finance of healthcare really matters. We have already discussed different levels of income pay different proportion or different levels of income make appropriately different payments. So, if it is then different and there is a possible explanation for vertical equity, and the extent to which people with the same income make the same payment is actually called horizontal equity. So, vertical equity so far as the clarification are concerned, this extent to which payments vary by income and can be measured by progressivity. So, and then progressivity of the healthcare financing system is called vertical equity. So, we are just taking a hypothetical example explaining these things vertical equity or from the progressivity context or regressive context or proportional spending context as a function of income. That is why we have classified in the entire data into 10 groups through their that is also called 10 deciles, and the mean income is presented here for your reference. Okay. And mean income at different group, the different income decile groups and their mean income is different in different level. Now, so far as the first decile is concerned, you can just see their income and the amount spent. Okay. So, you can see like with the rise in income, in this case rise in income is actually with the rise in income we are just comparing these what is their percentage they are actually spending. In the bracket we have percentages, okay, and the spending the annual amount spent for paying healthcare. This is what we have mentioned out of their income, that is 160 divided by 2000. Okay, 160 divided by 2000 is nothing but the 8%. Okay. Similarly, in the next income group or decile, it is 450 divided by 5000, it is of 9%. Now, it clearly suggests that with the rise in income, your percentage of healthcare spending annual healthcare spending is actually rising. You can see 9%, 10%, 11%, 12%, and so on. Hence, it is called progressive. Okay. And another interpretation of, so far as financing is concerned, poorest 10%, that is at one decile is 10% people, poorest 10% of the population are spending 8% for their health care. Okay. And the topmost, the richest 10% are spending 70% of their income on healthcare. Hence, it is progressive. So, progressive finance system, the proportion of income used to pay for healthcare increases as income increases. Just the reverse happens in case of regressive, healthcare spending. If you compare with income and their healthcare spending, you will just see the regressive trend, and you will find that as income increases, their percentage of spending for healthcare actually declines. So, initially then 340 divided by 2000, then 800 divided by 5000, okay, 800 divided by 5000 or 1350 divided by 9000, etc. Initially we derived 17%, then 16%, then 15%, and so on. You can see the topmost income earners or the richest most income group, or the top 10 income group spends comparatively very less, that is only 8% of their income on healthcare, whereas the bottom are actually incurring or bearing more cost for healthcare. Hence, this is called regressive. Whereas, in case of proportional one, every time it is considered to be a fixed proportion. So, you can see 240 divided by 2000, then 600 divided by 5000, and 1080 by 9000, etc. These boils down to only 12%. So, irrespective of the change in income, we know that income is actually rising. However, the percentage spent on healthcare is actually still constant. So, indirectly, though as per the percentage spending is constant, but indirectly we have already witnessed the rise in income. So, proportional rise is not necessarily good so far as distribution or equity is concerned. The progressive one is considered to be more vertically defining equity. One of the approaches in measuring equity is through Kakwani's progressivity index. So, progressivity of healthcare financing can be measured is through the Kakwani's progressive index as mentioned in 1977 paper. This measures the extent to which healthcare finance departs from proportionality, and that therefore we say their percentage is rising as against to income. And the figure here which we have cited, you can just guess from the diagram that this presents a Lorentz curve explanation, and where Gini coefficients used to be calculated, and that really measures the the distance from the 45-degree line, farthest the distance of that income line or the the spending percentage, that will clarify the extent of inequality. So, this figure shows concentration curves for income and for payments on healthcare. Now, we will also clarify that what is each of these direction, and here we are presenting the cumulative proportion of income or the the payments for health, and as against their cumulative proportion of population ranked by their income. So, the payment income concentration curve, where we are actually referring as a Lorentz curve, and the shape, that is CCYY, stands for the degree of inequality in the distribution of income. Okay. So, initially we started by presenting the 45-degree line, that basically precisely given equity in the structure. But but when we present the income inequalities index, and we derive their value as a proportion of the distribution of population by their income, we see there are inequalities. So, CCY presents the degree of inequality in the distribution income, where So, if income equally I mean if income changes, then or equally distributed throughout the population, CC okay. This point suggests that when income is equally distributed, then CCYY will be actually overlapping with the 45-degree line. That means there will be no inequality or inequity. So, CCYY refers to the poorest 50% of the population, where we have been actually indicating this point. So, this refers to the poorest 50% of the population earns only 30% of the total income. Now we are counting for the CCPY. This is actually the payment concentration curve, and this plots the cumulative proportion of the population ranked according to prepayment income against the cumulative proportion of healthcare payments. So, therefore, we say P, and interestingly we will see in reality also in different paper they highlight that this is in fact deviating from the 45-degree line and highlighting inequality, and this CCPY measures inequality in the distribution of payments for healthcare. Again, if it is actually equally distributed, then this will be also overlapping with the 45-degree line. So, and this indicates, I mean, a point if you just mark with the 50% of the population, okay, or the poorest or 50% of the bottom population or poorest population contributes to only 5% of the total payments for healthcare. This indicates that actually in reality that is true. Our society, especially in Indian society, more populations at the bottom section of income cannot able to afford for healthcare. Therefore, their total payment for healthcare is very less. Therefore, somewhere is reflected as only 5%. Okay. So, this is all about the directions for the Kakwani's progressivity index. We are going to clarify one by one again. So, we are just mentioning that payments as a proportion of income is constant in the constant curve, and sources of healthcare finance will be proportional. Then both the lines are, all three lines are actually coinciding each other in that case. So, no, if basically if you are referring to income, okay, income, if it is constant, okay, then and if the source of healthcare finance are proportional, that is constant, then these two are going to be equal. These two are same. All right. So, we are not actually, when I am saying it is actually inequality is perfectly same, and in both the case, then that will be coinciding with the 45-degree line. Okay. Otherwise, in this case we are saying if the change are proportional and income proportion is also constant, then these two lines are actually coinciding. With the rise in income, that is basically the progressive on the progressive changes in income, and the sources of healthcare finance is also progressive. In that case, then CCPY, that is on the healthcare spending, lies below the CCYY, and if that is just the reverse regressive, then CCPY lies above to CY, even CCPY will be higher than that of the CY. So, in figure CCPY lies here, we are saying that CCPY lies below, just to clarify that indicates health wise also inequalities are very high. Okay. So, financing system is progressive so far as I mean when CCPY lies below CCYY, finance system is progressive. The poorest 50% of the population earn 30% of income, but contribute only 5% payments for healthcare. The richest 50% of the population earn 70% of the total income and contribute 90% of the payments of the healthcare. Therefore, this indicates that the payment is actually progressive. Okay. All right. So, we are now explaining concentration index. The concentration index for income, that is CIYY, that is measured through the Gini coefficient, and that is used to be twice than the area between CYY and 45-degree line. So, I mean when we measure in terms of index value, it is estimated as the value is actually twice the area between CCYY, that means these two area, first range area, and then the value of the concentration is just double. So, the range of this is actually 0 to 1. If all income is earned by one person only, then of course, the concentration index value would be +1, okay, and income equally distributed, then that means if income is properly distributed, then CCYY as already mentioned coincide with the 45-degree line, hence there will be no inequality, hence CY index or the concentration value in terms of income is equal to 0. So, concentration index is calculated using either a convenient covariance formula or a convenient regression method, as mentioned in Donnell et al. 2008. And for so far as concentration index for the healthcare payments are concerned, it is again similarly the twice the area between CPY and the 45-degree line, this area and the value would be just twice. So, range is actually -1 to +1. That means that all healthcare is paid for by the poorest person. Okay, that means it will be at the extreme end, that is CI concentration index for the of PY, payment for healthcare will be -1, and if payments are equally distributed throughout the population, then of course it will be coinciding with the 45-degree, and hence CI concentration index of PY is equal to 0. Okay. So, Kakwani's progressivity index K is actually measuring this difference, that is CI PY minus CI YY. Okay. So, these two curved line, and their gap is actually nothing but called the Kakwani's progressivity index. So, that is precisely twice the area between these two gap. Okay. So, values of K ranges from -2 to +1, and there are number of calculations made, and based on the different authors and their reports, we just here presenting you the range, that is -2 to +1. And as I already mentioned, when K tends to or K is equal to -2, that means the extreme inequalities context, all payments for healthcare are paid by the poorest person, okay, and all income is earned by a single person, where in the +1 case both the two curved line will be similar, isn't it? All payments for healthcare are paid by the richest person and the income is equally distributed, okay, and this is how it is explained. So far as sources of healthcare financing is concerned, either it will be progressive or regressive. In the progressive case, the type of curve or the nature of curve, we have already mentioned that the CCPY lies below to that of the CCYY, and in that case Kakwani's K index value. So, hence it will be just higher in case of CIPY should be greater than that of CIYY. This is what is mentioned. Hence, K should be positive. In the regressive case, just the reverse is noted. You can just follow. If you have any clarification required, we will be happy to address in the clarification class or in the interaction class, live interaction session. Otherwise, in the proportional case, K would be 0. So, one case study we are just presenting in front of you just to understand the concept of progressive or regressive structure, and even you can also understand in which country they have which type of financing methods are followed. Wackstrup et al. 1999 paper based on 13 countries estimations are presented here, and data they have collected on payment income, direct out of pocket payments on healthcare and payments for private health insurance, and primarily from these are taken from household surveys. So, data on social health insurance payments and tax based payments either obtained from the same surveys or computed using data on the incidence of social health insurance payments are important and are also taken. Direct and indirect taxes such as tax files combined with the household survey data on income are all taken for the calculation. So, progressivity indices for total payments for healthcare in 12 of the countries combining tax payments, social health insurance payments and private health insurance and direct out of pocket payments are explained in this, are given in this table. You can see for all the countries, and their Kakwani's index value is also presented. You can just see from the result that based on positive and negative we already said, positive we have already said, and other values we have just interpreted, and accordingly we will further clarify. Now from the result you can see France, Germany, Netherlands especially, France, Germany and Netherlands, the value is very close to 0. France, Germany and Netherlands is very close to 0. Hence, that considered to be regressive structure. As they have the financing structure that is predominantly via social health insurance, okay, because individual income earners are actually not paying much. Hence, it is a regressive in those countries, France, Germany and Netherlands. And whereas in the tax based system wherever are followed, such as the countries like Denmark, Finland, Spain, Sweden and UK, you find the structure is largely proportional or even progressive. So, those countries you can see their values. Denmark, you just see Denmark, its value is minus 0.0047, and Spain it is actually 0.0004, okay, and so on. So, in wherever in Switzerland and USA, greater reliance on private health insurance, and since the government functioning or the government the public policy policies intervention in insurance market is very less. Hence, financing system overall is highly regressive, since it is the private parties who are actually bearing the burden. So, reliance largely on the private health insurance. So, however, there are some exceptions, especially in Portugal, total payments are regressive due to large proportion of direct out of pocket payments. Hence, it is actually regressive. Italy healthcare system is financed by equal mix of taxation as well as their social health insurance structure, and hence total payments are progressive. So far as horizontal equity is concerned, it is defined by comparing what people could pay for healthcare with what they actually pay, and in case of horizontal inequity, if people with the same ability to pay for healthcare but they pay different amounts for it, then it is actually called inequity. Horizontally they are capable to pay but actually paying differently, capable to pay equally but actually paying differently, that is therefore called horizontal inequity. Reasons for this is that it depends upon the financing structure, which already we cited the case of different countries. Maybe it is due to the direct taxation structure, or that varies from states to states or region to region, and this also arises due to the indirect tax structure. If people in the same income group consume different amounts of taxable goods. Hence, social health insurance structure is also very important. This in the case of horizontal inequity, if households with similar income are members of different social health insurance schemes with different payment schedules, then horizontal inequity is resulted. This might arise because they are in different occupation groups as well. Now, coming to private health insurance, horizontal inequity occurs because it is not compulsory, and people with the same income may make unequal payments as well if they choose to buy different levels of insurance cover. People with the same income will pay different private insurance premiums if they have different risk status. Hence, that is to large extent defined as inequity, horizontal inequity. Direct out of pocket payments is also explaining the context of horizontal inequity. This arises because of the fact that individual are actually different in terms of their incidence of cases of health. They might be ill and their preference of use of health services across people with same income. Since this varies, so out of pocket actually payments are different even with the same income level. Various measures of horizontal inequity in finance have been developed. In their approach, horizontal inequity is measured by variation in healthcare payments among groups of people or household with the same prepayment income. And if no variation within the each group, then horizontal equity, and if variation, then of course it is considered as horizontal inequity. So, variation in payments measured using the concentration index for payments. We have already mentioned through the Kakwani's aspect index, that is through the CCPY in the diagram. So, an overall index of horizontal inequity by taking a weighted sum of these concentration indices are across all groups are important. However, little empirical work is made to investigate horizontal inequity in healthcare financing, and this is because this requires many concentration indices for payments, one for each income group as mentioned in the Wagstaff and Dorseller in 1997 work. So, that is all. I think we have dealt with various aspects of equity and vertical equity, and even we clarified about different contexts and the possibility of horizontal inequity. So, in the next lecture we will give you further details on horizontal inequity, and their case study will also be discussed. So, that is all on for today. We will be also emphasizing in the next lecture on horizontal equity, their distribution, etc. So, with this I must stop here. Thank you.